Thank you for that kind introduction, and thank you for your kind invitation to speak at this meeting in Utah. And that's a picture of one of the most beautiful places in Utah. I have no declarations, and this is greetings from Singapore, our small country, to be talking about a slightly bigger topic. The approach to metabolic neuroimaging is actually very difficult, and the numbers of conditions that we have to cover is quite vast. So I will be talking a little bit about how to approach it, primarily because many of these systemic diseases are bilaterally symmetrical. Metabolic diseases can be inborn errors or can be acquired and could be also toxic, and I'll go through a few examples of both. One of the hallmarks of neuroimaging as a diagnostic radiologist is that we look for focal lesions. And here's an example of an ACA territory stroke on DWI and a large tumor, which is a meningioma on one side. Both of these violate the principle of the bilateral symmetry of the brain, seen here on the picture on the left, which is normal. However, metabolic and systemic diseases are subtle in their findings because they have bilateral and symmetrical involvement in many instances. Here's an adult with hypoxic ischemic injury, out of hospital, cardiac arrest with resuscitation, resulting in hypoxic ischemic injury involving both the deep gray matter, the putamen, the globus pallidus, and even the thalamus bilaterally, as well as the cortex, very widely distributed throughout. So some of these findings may not be easy to detect if they are bilateral. So first thing we have to ask is this a diffuse or a focal lesion? Systemic diseases tend to be affecting those that are metabolically the most active. And in the gray matter, that would be the basal ganglia and the cortex. But bear in mind that very often the white matter is also affected. And we've also seen instances of white matter leukoencephalopathy turning up in acquired metabolic diseases as well. The generalized disease tends to be inborn errors in younger children, but we have to be aware of mimics. So there are a very large number of confusing lists, and as radiologists, we tend to see only a very small spectrum of those that are more common, and we try and impose some order out of the very large and sometimes chaotic seeming lists. And inborn errors present systemically with metabolic abnormalities, classically acidosis, ketosis, that sort of stuff, and very often involving multiple organ systems, and that should be a first clue. The CNS is often affected. The musculoskeletal system and the visceral organs should also be checked for other supporting findings, such as bones and liver. The age of onset, the earlier the patients present, the worse the prognosis and the severity will become in the general rule of thumb. But we have to be very aware that many of the findings can be nonspecific. You might just have CT finding of brain swelling, atrophy, delayed myelination, and not a whole lot else. However, what is good is that there are some textbook specific patterns that we can use, and those that are affecting the deep gray. And we use spectroscopy and DWI because they're very sensitive and conspicuous for DWI, and sometimes MR spectroscopy can give you a clue in specific instances, but not all the time. Be aware, overlap and atypical features are very common, and very often you will have unknown, undiscovered white matter diseases that have yet to be named that will eventually get published one day. So the definitive diagnosis requires a lot of collaboration between the radiologists as well as the clinicians and the various geneticists and laboratory experts. So a multidisciplinary approach and good collaboration is very important. The findings are best matched with a good textbook, all right? And very often the delayed and hypomyelinated diseases can show up, and CNS malformations can be the first clue, but this list of findings is pretty nonspecific, and many patients, as I've said, end up in late atrophy. So just as an example, and this is typical of what sort of lists we can look forward to in the definitive textbooks, dysgenesis of the cerebellum. That means anything abnormal in terms of hypoplasia, dysplasia of the cerebellum can arise from a very long and different list, but it's difficult for us to remember these things, and I don't really bother. But the effect of the gray matter can be helpful in helping us see this. And when it comes to the cortical gray matter and the deep gray matter, the latter has a very much better discriminating capability. For instance, most of the diseases are hyperintense on T2, but a few are hypointense on T2-weighted MR images. And in the cerebellar and the brainstem, there are a few distinguishing features that might be helpful for us to look at. So the classic examples of some of these findings would include, as I've circled here, those that are hyperintense, bilateral, symmetrical in the deep gray nuclei, Leigh Disease, and the mitochondrial abnormalities, followed by Wilson's disease, which is a copper abnormality. The hypointense poster boy is PKAN, which we'll talk about later. And in the cerebellum and brainstem, bear in mind that many of the conditions that are listed on the left-hand column can also appear and give rise to some abnormalities, which may be helpful in distinguishing them, particularly in the brainstem, such as the periaqueductal gray, involving much of the Leigh disease. Many of the conditions will involve both gray and white matter, and sometimes it's helpful to look outside the brain and look at some of the bone radiographs, where mucopolysaccharidosis and a couple of other syndromes are important. And again, if it is primarily striatal, that list of Leigh disease and mitochondrials is important. But bear in mind that those are, that are in purple, which are primarily white matter disease, can involve both gray and white matter in addition to the others. And the purely white matter disease list is the very familiar X-linked adrenoleukodystrophy, as well as others, and then Alexander disease and other types of leukodystrophies. So let's look at a few typical examples. The poster child for the deep gray matter is, of course, mitochondrial disease. And these are very active, and therefore there's selective vulnerability in the gray matter, particularly the deep gray, but also in the cortex for MELAS. So the classic pattern is deep nucleus and cortex. And MERF is primarily a muscle disease, which we don't come across very often, likewise Kearns-Sayre disease. So Leigh disease, typically bilateral symmetrical involvement with T2 prolongation of the basal ganglion and the globus pallidus. And diffusion-weighted MR image gives you cytotoxic edema with reduction in ADC. And lactate appears on the MR spectroscopy, which is a good marker for mitochondrial diseases. And here's another example where there is high signal intensity on both T2 and DWI, as well as involving the brainstem and the periaqueductal gray matter. Here's that lactate peak, which we typically can see. And the clinicians can also find lactate in the blood and the CSF, which is a good confirmation. And if we see this, the patient can get referred to genetic testing for mitochondrial diseases. MELAS is classically the cortical equivalent, where there is a stroke-like syndrome with patients with headache and non-specific encephalopathic appearances, where it does not conform, the lesion does not conform to the typical vascular territory. But in some instances, there can be a bit of overlap. And the diffusion-weighted MR image finding is still fairly equivocal. Initially, it was described as vasogenic edema without restriction, but there have been case reports where there is restricted diffusion in some of these cases. And again, the classic spectroscopy finding would include the presence of lactate. So some of these patients can be very surprising, and they can masquerade with a whole bunch of differential diagnoses, and the clinical symptoms are very nonspecific, such as in this particular patient who had an acute attack. And during that, we realized that there was stigmata of previous abnormalities, and we know that in MELAS, the posterior portions of the cortex are quite often affected And then when they resolve, they don't completely disappear, nor do they have encephalomalacia like what you'd expect from real stroke. So they may leave tantalizing clues as to the differential diagnosis, and when we added spectroscopy, we had much better understanding that there was the presence of lactate. And these patients, like I said, can be great mimics, and one of these mimics and difficult conditions that we do is Hashimoto's encephalopathy, and there's a lot of debate as to what that might be. And this patient presented as what we thought was that, but we realized that there was something odd about this patient, and we did the spectroscopy, and we were able to reach the correct diagnosis. So I said that Leigh disease typically affects the basal ganglia, whereas MELAS typically affects the cortex. But bear in mind that in MELAS, both the cortex and the basal ganglia can be affected. And this was a patient who presented with MRI, and we saw these very nonspecific cortical high signal intensities on T2, FLAIR, and diffusion-weighted MR image. But when we did the CT following that, we discovered that there was probably long-standing recurrent attacks giving rise to calcification of the basal ganglia. Now, the poster child for the dark basal ganglion abnormality basically is this group of patients now called NBIA and PKAN. Used to be called Alverden-Spatz disease. Now with better political correctness, we prefer the NBIA diagnosis. And the typical findings are that of those patients who have the PKAN2 mutation, giving rise to the classic eye of the tiger sign that we see in all the textbooks, where there's low signal intensity surrounding the high signal intensity of the active destructive lesion caused by ion destruction in these patients. Now, Wilson disease is something that affects both the basal ganglion and the thalamus. And here's a patient who has a presentation at a young adult age. So some of these patients may not be purely pediatric or young children, but this patient at 16 years old started presenting with hand tremors and poor coordination. And when we saw this, there was a whole lot of different things that we had to think about. And one of the easiest things we said whilst waiting for the ceruloplasmin to come back was check the eyes. And of course, we found the KF rings of copper deposition. Next, the poster child for white matter disease would be the leukodystrophies. And one typical example would be Alexander disease, where there's frontal distribution of bilateral symmetrical high signal intensity in this child on T2 weighted MR image, and decreased signal intensity on T1. Unlike the other gray matter type abnormalities, this patient did not have restricted diffusion on the DWI. And we haven't had a lot of experience with the spectroscopy of these patients. We just had decreased NAA and slightly elevated choline. But on the short echo time, there's a whole bunch of stuff that's waiting to be discovered, and I have no idea what many of these things mean in individual patients, but I'm sure that there will be good work that's going to come out soon. And this is a more recent paper talking about hypomyelinating as opposed to the full-blown demyelinating disorders. And again, as I've mentioned, people try to impose order on the chaos, and they have gone through sort of a flow chart of what you can expect from looking at hypointensity on T2, yes or no, and then if that's a no, you move on to talking about what's happening in the basal ganglion, and so on, and eliminate or rule in or rule out all the different types of hypomyelinating disorders, including GM1, GM2, and Pulitzer, M.B.B.S disease, and some of the rarer and more exotic variants. So those are the gray matter, the white matter, and the hypomyelinating and leukodystrophy white matter diseases. In newborns, there are fewer patients who manifest at that young age. But in neonates, maple syrup urine disease is something that we should be aware of. And here's the full list of devastating metabolic diseases. Most of them are very rare, but we've come across a few cases of these patients with MSUD. And this is very typical in a patient who is a neonate who has not had a lot of myelinated white matters, but what is myelinated is completely abnormal. So those early myelinating white matter tracts in the cortical spinal tracts, in the white matter that is already myelinated at birth, are badly affected, restricted diffusion, high signal intensity on DWI, and you can appreciate that on the T1 and T2 there's not a whole lot of contrast between the badly affected tissue and those that are not. Next we come to urea cycle abnormalities. This is a place where potentially MR spectroscopy can be helpful. Here's where there's a single enzyme defect that results in accumulation of some products and decrease in other products. And this is an example of the different types of urea cycle abnormalities. And so if there's an OTC, ornithine transcarbamylase deficiency, there will be increase in citrulline and increase in glutamate metabolites, as well as ammonia, which can be detected in the circulating blood, and decrease in some of the other metabolites. So here's an example where citrullinemia, which is the disease of adult onset OTC deficiency, can give rise to increase in glutamate, which sometimes we can see as radiologists. So here's a patient who has an unsuspected adult onset version of hyperammonemia, and we were wondering what this patient had, but what he did have in terms of the MRI was bilateral, almost symmetrical involvement of the insular cortex and the cingulate gyrus. There was also involvement to a lesser extent of some of these other areas. And the cause of increased ammonia, the most common would be adult acute hepatic failure, typically after TIPS, where you can see pretty much the same thing. But this patient did not have liver failure and his liver enzymes were normal. The other types of like OTC deficiency and citrullinemia that I mentioned just now were eventually investigated. And there may be situations where laboratory tests can see this, and for us, in terms of MRI and MR spectroscopy, it turns out we can see the increased glutamate as an elevation of the GLX complex on short echo time MR spectroscopy. And here it is in all its full glory, and we can make the diagnosis, especially on our second case, because the first case we had absolutely no idea what was going on. So that's for adult onset. For the slightly younger patients, the cingulate gyrus and the insular cortex are also involved. But for neonates, it's a slightly different presentation. If you have ASS deficiency, all we have is destruction of the cortex, primarily, with a eulygyric presentation and involvement of pretty much the depths of the cortex, which is also found in the adult portion. So as I'm about to finish, we will be talking a little bit about acquired metabolic diseases. Don't forget, in many patients, not all pediatric disease is inborn errors. And hypoxia, hypoglycemia can also give rise to abnormalities. And here, the first example that I showed you of widespread gray matter involvement can be a manifestation, as can this, because this is a 13-year-old boy who had a near-drowning episode of asphyxia and hypoxic ischemic brain damage. And the T2-weighted MR image was a little odd, but on the DWI and the ADC, you can see that there is very extensive white matter, decreased ADC due to delayed anoxic leukoencephalopathy. And this has been quite well described in patients with anoxia, particularly carbon monoxide poisoning. PRES is also a metabolic disease, primarily affecting the white matter, but also encroaching onto the gray matter. These patients are typically going to do well because it's posterior and reversible, but bear in mind that some cases, especially those that hemorrhage, don't do as well as the straightforward cases. So there's always caveats and pitfalls. And the limitations of neuroimaging, of course, is that I've showed you all the typical barn door textbook type cases. There are always going to be overlaps, atypical features, and although T2-weighted MR images are the mainstay of imaging, Sometimes we need T1 weighted MR image to help us find some of these metabolic abnormalities. And DWI is really good for lesion detection, especially the case I showed you of maple syrup urine disease. So the differential diagnosis of bilateral symmetrical abnormalities of the basal ganglion and or the thalamus needs to be something that we bear in mind. And among the list of abnormalities would include the usual suspects that I've mentioned of metabolic diseases as well as toxic poisoning, but also bear in mind that vascular, inflammatory, and neoplastic diseases can also affect the deep nuclei bilaterally. So in summary, I've tried to go through very quickly to try and impose some order on the complexity and the long lists of metabolic diseases, and they tend to be bilaterally symmetrical or midline like cerebellar lesions. And of those, the gray matter typically are involved very prominently. Metabolic diseases are both inborn errors of metabolism as well as acquired and toxic, and we hope that we will remember that if it's bilateral, think about this, put these pulse sequences into place, look at simultaneous abnormalities, not just the gray matter, but also the cortex, the white matter, and the brainstem, and then correlate with clinical and laboratory findings. So this is a picture of Bryce Canyon, one of the most beautiful places in Utah, and each one of these could represent a small, unknown metabolic disease. Thank you very much.